All right, colleagues, welcome. Today, we're going to do a deep dive into two conditions that are, without a doubt, the absolute bedrock of any pediatric dermatology practice. Let's jump right in.
Look, infantile hemangiomas and atopic dermatitis, you are going to see these constantly, day in, day out. Mastering all their little nuances, from getting the diagnosis right the first time to knowing all the latest therapies, it's absolutely essential if you want to provide top-tier care. So this session is all about sharpening those skills.
So we're going to start with infantile hemangiomas, because before we can even think about treatment, we have to have a rock-solid diagnosis. And, just as importantly, we need to know what the red flags are.
So what is an IH? At its core, it's defined by its unique life cycle. There's this phase of really rapid growth, and then it hits the brakes and begins a slow, spontaneous regression. Understanding this timeline is absolutely fundamental, not just for your diagnosis, but for counseling anxious parents.
Okay, this is probably your first and most critical challenge in the clinic, telling an IH apart from a vascular malformation. Look at that timeline again. IHs explode after birth. Malformations are there from the get-go and just grow with the child. But the definitive, black and white test, it's on a slide. IHs are GLUT1 positive. That is the pathognomonic stain. It's your gold standard. End of story.
So who gets these? Well, you'll start to notice some patterns. There's a really strong link to female sex and prematurity. In fact, a low birth weight is a major independent risk factor. You know, this association with being premature and having placental issues really points toward hypoxia, a lack of oxygen, as a key player in how these things develop.
This timeline is everything. You need to have this memorized. That 5 to 8 week period, that's when growth is fastest. That is our critical window for intervention if we need it. Think about it. By just 3 months of age, that lesion is already about 80% of its final size. This timeline is one of your most powerful diagnostic tools.
Now, we have to talk about the times when an IH is not just a benign skin lesion. A large, segmental hemangioma on the face is a massive red flag. This should immediately make you think of PACE syndrome. You have to initiate a full workup. We're talking an MRI/MRA of the head and neck, an echocardiogram, and an ophthalmology consult. This is not just skin deep. And the exact same principle applies as we move down the body. You see a large segmental hemangioma in that lumbosacral area, your brain has to go to lumbar syndrome. Your workup here needs to include an abdominal and pelvic ultrasound and a spinal MRI to look for things like spinal dysraphism. Recognizing these patterns is absolutely non-negotiable.
So once we've established our diagnosis and we've screened for those serious red flags, we can finally pivot to management. And believe me, the way we approach this has evolved dramatically over the last couple of decades.
Our goal is really a delicate balance, isn't it? We want to prevent complications and disfigurement, for sure. But we also have to respect the natural course of involution. The real art of our job is knowing when to treat versus when to actively watch and wait.
So what's the most common reason we have to intervene? Ulceration. It affects up to 10% of these lesions. And this isn't a small thing. It's incredibly painful for the infant, and it dramatically raises the risk of scarring and infection. You need to be extra vigilant with those lesions on the lips, in the anogenital area, and tucked away in skin folds.
Propranolol. I mean, this was a revolution, a complete game changer. This non-selective beta blocker is now the undisputed first-line systemic therapy for any complicated IH. It completely replaced systemic corticosteroids because it's just so much more effective and safer.
But using it requires a careful, stepwise protocol. After you do your risk assessment, your most important job is counseling the parents. You have to hammer this home. Give the dose with food to prevent hypoglycemia. Then we start low, titrate up slowly to our target of 2 to 3 milligrams per kilogram per day, and we're monitoring their vitals carefully at every single step.
Okay, let's switch gears completely. Time for our second topic, atopic dermatitis. If you really want to manage this effectively, you have to start with understanding why it happens, the pathogenesis.
Please never forget this fundamental concept. It is the intense, relentless itch that is the primary symptom. The eczematous lesions we actually see, the redness, the scale, the thickened skin, all of that is secondary. It's the patient's response to that unbearable itch. If you manage the itch, you are managing the disease.
The pathogenesis is really a triad, and it all starts with a defective barrier. Think of the skin like a brick wall. Filaggrin is the mortar holding the bricks together.
In many of these patients, especially those with mutations in the filaggrin gene, that mortar is faulty. This faulty barrier lets water out, causing dryness, and lets irritants and allergens in, which triggers inflammation.
So, second, with that leaky barrier, the immune system goes haywire. It overreacts with what we call a Th2 skewed response. This is driven by specific cytokines, mainly IL-4 and IL-13. And this is so important because these cytokines are the exact targets of our modern biologic therapies.
And the final piece of this puzzle is the microbiome. The skin of a patient with atopic dermatitis is a different world. Over 90% of them are colonized with Staphylococcus aureus. And Staph aureus isn't just a bystander. It actively fuels the inflammation and further damages the barrier. It creates this horrible vicious cycle of itch and rash.
So, keeping that pathogenic triad in mind, the bad barrier, the overactive immune system, and the altered microbiome, how do we actually approach treatment? Well, our modern strategy has shifted pretty significantly.
First off, you have to recognize that atopic dermatitis is a clinical chameleon. It looks totally different depending on the patient's age. You go from those weepy red papules on an infant's cheeks to the thick, lichenified plaques in the crooks of the arms and knees in a child. Knowing these classic patterns is absolutely key to your diagnosis.
Now, this is critical. Our whole approach has shifted from being reactive to proactive. The absolute foundation is barrier repair with daily moisturizers. We use topical steroids to put out the fires and get control of a flare. But then, and this is the key, we use maintenance therapy like topical calcineurin inhibitors to prevent the next fire from even starting. And for severe disease, we now go straight to the source, targeting the immune system with systemics like dupilumab or the JAK inhibitors.
Okay, we have covered a tremendous amount of ground. Let's take a minute and distill all of this down to the high-yield pearls that you can take directly into your clinic tomorrow.
Let's recap. For hemangiomas, GLUT1 is your stain and segmental lesions demand a full workup, every time. For atopic dermatitis, barrier repair is the non-negotiable foundation of everything you do. Manage proactively. And for both of these conditions, educating the family is just as important as the prescription you write. Remember, treatments like propranolol and the new biologics have completely transformed outcomes for these kids.
And that leaves us with one final thought. We've gotten really good at managing these diseases, but the next frontier, the real challenge for your generation, is prevention. With everything we now know about barrier dysfunction, how can we intervene even earlier to stop these conditions before they even begin? That's the challenge that's going to define the future of our field.